Hi students, welcome to my channel Nursing Guru. Today we will learn about neonatal jaundice. At the end of this topic, I will provide the questions related to this disease condition asked in previous exams. Well, let's start with the definition of jaundice. Jaundice in general terminology is the yellowish discoloration of skin and sclera. Jaundice occurs when there is high level of bilirubin in blood, that is called as total serum bilirubin. I told bilirubin. Then what is bilirubin? Bilirubin is the yellow substance that is produced when RBCs are broken down or destructed. Bilirubin is the byproduct when RBCs are destructed. Normal bilirubin level in a newborn baby's blood is 0.3 to 1 mg per deciliter within the first 24 hours of life. If it is more than 2 mg per deciliter, is called as jaundice or hyperbilirubinemia. Hyper refers to increased level, bilirubinemia refers to bilirubin level in blood. Hence, hyperbilirubinemia meaning is increased level of bilirubin in blood. As we all know, liver is responsible for filtering bilirubin from blood and excess bilirubin is excreted through stool. If the liver of babies is not completely developed or if it is immature, excess bilirubin build up in the baby's body and causes increased level of bilirubin. Hence, there will be yellowish discoloration of skin and sclera of eye. I told total serum bilirubin. If it is between 2 to 3 mg per deciliter, then sclera will be yellow. If it is between 4 to 5 mg per deciliter, face will be yellow. Next, we will see the definition. Neonatal jaundice is a condition in which newborn baby's skin and eyes appear yellow due to high levels of bilirubin in their blood. I repeat, neonatal jaundice is a condition in which newborn's skin and eyes appear yellow due to high levels of bilirubin in their blood. Neonatal jaundice is more common in premature babies. Next, we will see the types of neonatal jaundice. Mainly, there are two types of jaundice. One is physiological jaundice, second one is pathological jaundice. First one is physiological jaundice. Physiological jaundice is the most common type of jaundice. Here, bilirubin level will be less than 15 mg per deciliter, and this type of jaundice occurs after 24 hours of life or birth. It occurs due to immature liver. As the name suggests, physiological refers to function. Here, function of liver is altered or it is immature. Hence, it occurs due to immature liver. And this type of jaundice disappears without any treatment. Sometimes such babies need phototherapy. Second type is pathological jaundice. As the name suggests, it occurs either due to infections or any surgical problems. Here, bilirubin level will be more than 15 mg per deciliter and it occurs within the first 24 hours of life. Such babies need supportive management or some surgical corrections in later life. Other types of hyperbilirubinemia or jaundice. Breastfeeding jaundice. This type of jaundice occurs when baby doesn't get enough breast milk from mother to lower their bilirubin levels. I repeat, this type of jaundice occurs when baby doesn't get enough breast milk from mother to lower their bilirubin levels. Another type is that is breast milk jaundice. This type of jaundice occurs when some substance in a breast milk prevents breakdown and processing of bilirubin. This type of jaundice occurs when some substances in breast milk prevents breakdown and processing of bilirubin. As I told earlier, the cause for physiological jaundice is immaturity of liver. Immaturity of liver can't process bilirubin, hence it leaks in blood and settles in skin causes yellowish discoloration of skin. Second, I told pathological jaundice. Pathological jaundice either occurs due to unconjugated hyperbilirubinemia or it may occur due to conjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia may occur either due to non-hemolytic causes or hemolytic causes. Hemolytic or non-hemolytic causes may cause unconjugated hyperbilirubinemia. Conjugated hyperbilirubinemia occurs due to hepatic and post-hepatic causes. Later, we will discuss them. First one, unconjugated hyperbilirubinemia in that hemolytic and non-hemolytic causes. First one, the hemolytic causes includes Rh incompatibility, hematoma, polycythemia, some drugs, and sepsis may cause unconjugated hyperbilirubinemia. First one I told Rh incompatibility. If Rh positive baby is born to a Rh negative mother, that can cause hemolytic anemia. Again, hemolysis of RBCs causes increased level of bilirubin in blood. Second, I told hematomas. In that, either cephalohematoma may cause unconjugated hyperbilirubinemia. Cephalohematoma is a birth injury that can occur when a newborn head is injured during childbirth, where the blood comes outside and is absorbed in the body, causes rise in bilirubin in blood. In cephalohematoma, if newborn's head is injured during childbirth, the blood comes outside from that blood vessels and is absorbed in the body, can causes rise in bilirubin in blood. Another part in hematoma is large vessel injuries. In large vessel injury, a hematoma can form and it can obstruct the bile duct, which can lead to jaundice. A hematoma from a large vessel injury can obstruct the bile duct, which can lead to jaundice. Then third, I told polycythemia. Polycythemia is a condition in which there will be production of too many RBCs from bone marrow. In polycythemia, too many RBCs are produced from bone marrow, and when they are destructed in large number, again they release larger amount of bilirubin. Then I told some drugs like diazepam, steroids, oxytocin may increase the level of bilirubin. Next one, sepsis. Sepsis disrupts the body's ability to process the bilirubin, hence the bilirubin remains in the blood, causes jaundice. These are the hemolytic causes for unconjugated hyperbilirubinemia. Then what are the non-hemolytic causes? Non-hemolytic causes include breast milk jaundice. As I told earlier, it occurs when baby doesn't get enough breast milk from mother to lower their bilirubin levels. Second one, Gilbert syndrome also causes unconjugated hyperbilirubinemia. Gilbert syndrome is a genetic disorder that prevents bilirubin processing in liver. Another one is hypothyroidism. Hypothyroidism reduces the activity of enzyme. The enzyme is UGT. Hypothyroidism reduces the activity of enzyme responsible for bilirubin processing in liver. UGT is the enzyme responsible for bilirubin processing in liver. When there is hypothyroidism, it reduces the activity of the enzyme of UGT. Uridine diphosphate glucuronil transferase is the enzyme responsible for bilirubin processing. Next, we will see conjugated hyperbilirubinemia. Conjugated hyperbilirubinemia occurs due to hepatic causes and post-hepatic causes. In hepatic causes, idiopathic neonatal hepatitis, some infections, and some inborn errors of metabolism may cause hyperbilirubinemia. I told idiopathic neonatal hepatitis. Idiopathic neonatal hepatitis refers to inflammation of liver that leads to poor bile flow in the liver. It is the inflammation of the liver that leads to poor bile flow in the liver. The cause for this type of hepatic cause or idiopathic neonatal hepatitis is unknown. Next, I told infections. Some infections like torch infections. Torch refers to toxoplasmosis, rubella, CMV, cytomegalovirus, herpes simplex, and sometimes sepsis also causes conjugated hyperbilirubinemia. Next, inborn errors of metabolism like hepatomegaly, splenomegaly may also cause conjugated hyperbilirubinemia. Next, post-hepatic causes. In that, biliary atresia or bile duct stenosis may cause hyperbilirubinemia. Biliary, biliary atresia is the disease condition where bile ducts are blocked, preventing bile from flow from liver to small intestine. In biliary atresia, there is the closure of duct that prevents the flow of bilirubin from liver to small intestine. Hence, the bile juice remains in the liver, causes increased level of bilirubin, that in turn causes hyperbilirubinemia. This is about conjugated hyperbilirubinemia. Next, we will see the investigations which are needed for identification of hyperbilirubinemia. First one, bilirubin measurement. Bilirubin measurement can be done by either serum analysis or transcutaneous blood bilirubin by bilirubinometer. Bilirubinometer is the device used to identify the bilirubin level. Next one, we can do CBC. CBC measures the number of RBCs, WBCs and platelets. Next, we can do reticulocyte count. Retic count. The normal retic count or reticulocyte count is 2 to 6 percentage. If it is more than 6 percentage, that indicates hemolysis. That means increase in RBC breakdown. Next, blood grouping can be done to know the rhesus factor or RH compatibility. Next, we can do Coombs test that detects the antibodies attached to the RBCs. That is the potential cause of hemolysis. Next, we can do urine microscopy, culture and sensitivity that shows urinary tract infections or any other infections. Urea and creatine can be done. LFT, liver function test, also can be done to know the hepatic causes. Then we can do USG that shows splenomegaly and hepatomegaly. Thyroid function test can be done, that is needed to identify any congenital hypothyroidism. Management of hyperbilirubinemia includes first one, history taking, second one, examination of newborn, third one, treatment of unconjugated and conjugated bilirubinemia. First, we will see the in detail history collection. History collection or history taking includes in detail maternal history, that includes antenatal history regarding any illnesses or any infections, drug history like non-steroidal anti-inflammatory drugs, NSAIDs, or some herbals, medical history that includes blood grouping, hemolytic disease, any liver diseases, family history includes any siblings with jaundice or familial jaundice, and birth history includes any traumas or cord clamping. Second one, examination of newborn. Examination of newborn includes examination of yellowish discoloration of skin or sclera or hepatosplenomegaly or any fever or weight loss, and observe for yellowish discoloration that usually progresses from face and proceeds towards abdomen as serum levels increases. Kramer's rule is used to describe the levels of bilirubin in the blood. What is Kramer's rule? Kramer's rule is non-invasive method of assessing the degree of jaundice. Kramer's rule is the non-invasive method of assessing the degree of jaundice. It includes 5 dermal zones. Kramer's rule includes 5 dermal zones. They are based on the progression of bilirubin. The dermal zones are like 1, 2, 3, 4 and 5. Dermal zone 1 indicates that yellowish discoloration of face and where the bilirubin level will be 4 to 6 mg per deciliter. Dermal zone 2 indicates yellowish discoloration of skin over the chest and upper trunk, and that indicates 8 to 10 mg deciliters of bilirubin. Dermal zone 3 indicates yellowish discoloration of lower abdomen and thighs, that indicates bilirubin level of 12 to 14 mg per deciliter. Dermal zone 4 refers to yellowish discoloration of skin over forearms and lower limbs. Again, that indicates the bilirubin level of 15 to 18 mg per deciliter. And the last one, dermal zone 5 indicates yellowish discoloration of all the above and including palms and soles. That indicates the bilirubin level more than 15 to 20 mg per deciliter. Third one, treatment of unconjugated hyperbilirubinemia. The aim of this treatment is to reduce bilirubin level in blood and to prevent bilirubin encephalopathy, that is kernicterus. What is kernicterus? Kernicterus is a serious brain condition. It is a type of brain damage caused by bilirubin, where bilirubin crosses blood-brain barrier and causes damage to brain and spinal cord. Kernicterus causes brain damage that is caused by bilirubin, where bilirubin crosses blood-brain barrier and cause damage to brain and spinal cord. In a simple way, kernicterus is the complication of hyperbilirubinemia. Next, management includes phototherapy. For phototherapy, I made a separate video. Please see that video. And we can do exchange blood transfusion, that is whole blood transfusion for rapid RBC destruction. Pharmacotherapy includes phenobarbital. Phenobarbital increases hepatic uptake of bilirubin. The dose is 5 to 8 mg per kg per day. And the treatment of conjugated bilirubinemia includes supportive management like parenteral vitamin K injection and vitamin A and D supplements. Vitamin A and D supplements prevents rickets. Then phenobarbital again can be given, that helps the bile excretion. That helps in bile excretion. Then in later age, surgery may be needed for biliary atresia or bile duct stenosis. Then prevention of hyperbilirubinemia can be done by early breastfeeding, that is for about 8 to 12 times a day during first week of life. Thank you.